Are you on?
Yes,
Dr.
madam.
Are you on?
Yes, madam.
Dr. Venkat?
Yes, madam.
Okay, so as I said, volume outcome relationships are often present when technically sophisticated care like ECMO is being delivered by an experienced and organized medical team. In some studies which have been done by Karamalu et al. And Freeman et al., most of the studies have mentioned volume outcome of a hospital in terms of performing ECMO, in terms of age. They have taken age groups between 1 to 14, the neonatal and the pediatric age group, the adolescents and the adults, young adults between 15 to 30 and more than 30. And they have found out that there is to adjust or ratio to mortality. More than in the pediatric, it is in the adult that the value of less than 1 comes. The odds ratio and the confidence interval better in adults than in pediatrics. Meaning to say that if we have experience, this is an expert team as far as performing a high volume or number of cases of ECMO are present, the outcomes are very good. But if we compare the outcomes between the pediatric and the adult patients, they are better in the adults than in the pediatric or the neonates. So hospitals with higher annual ECMO patient volume have a lower case adjusted hospital mortality rate. And this methodology is now, what I am talking of now, are some talks and some work which is done, as Dr. Venkat was saying very nicely. It is the ELSA registry which has the largest database. I come from a tertiary care center like AIMS, where we perform about 2 to 3 ECMO a week at least, and most of the ECMO that is performed in AIMS is the veno arterial ECMO. But between 1989 and 2013, and then again between 2008 to 2013, the data by ELSO world over was taken up in up to 60,000 patients. And this is a data which they have been able to gather over a period of less than 6 to 7 years in 290 centers. And as I said earlier, they have divided the period amongst neonates in babies less than 1 month, pediatric which between 1 month to 18 years, and adults more than 18 years. And on applying logistic regression analysis on statistics, when accounting for the clustering of patients within hospitals, adjustments were made for patients' age, calendar year patients receiving ECMO, the ECMO support time, whether it was the venous or the veno-arterial, and the presence or absence of comorbid conditions. And they adjusted this ECMO data to the patient's PF ratio, on pulmonary function test, and on arterial blood gas with the patient's index and PPO2, the duration of mechanical ventilation, and the presence or absence of acute renal failure. They found results of both centers, 900 centers, that in almost all centers there was a growth in the performance of ECMO, and they found a good volume outcome relationship. And this is what the relationship said. If you can see, in terms of years from 1989 to 2013, almost 22 to 23 years, the neonates, the number of cases done were maximal, the pediatrics were next, and the adults which were low-lying in the earlier months, actually it is the literature on ECMO worldwide. It is the mini-influenza pandemic, which in 2009 led to an increase in the performance of the adult ECMO for ARDS or for patients who were performing VV ECMO for these adults who had some kind of respiratory failure. At our center too in AIMS, we do not have any data or very little data, as I would show you later, on adults or on VV ECMO. We perform all our VV ECMOs for arterial switch operations for CHPCs and for L-kappa patients on neonates or pediatric patients. Now, the results of the ELSA registry has been listed as it is shown. You have the neonates, pediatric, and the adult population, and the hospital annual volume of ECMO is divided between those centers which have 1 to 5, 6 to 14, 15 to 30, or more than 50. So next few slides would be based on this. As I said earlier, the adjustments were made for patients receiving ECMO in terms of their age, the kind of ECMO being given, whether it was respiratory, cardiac, or emergency CPR ECMO. Calendar year patients when they received in which year, the ECMO data such as pH, CO2, ratio, the duration of mechanical ventilation, or the presence of acute renal failure or cardiac arrest. And if you consider the neonatal period between 6 to 14 and more than 30, you can see the odds ratio was better in the more than 30, where the volume was more. So those patients where the ECMO volume was more than 30, the odds ratio was lower. The lower the odds ratio, less than 1, the lower the confidence interval, the 95 confidence interval, the better the linear relationship between the ECMO and the outcome. So those patients, as you can see in the neonates between 1989 to 2013, 1 to 5, the odds ratio was reference. We did not get good, they didn't get good ratio, but it was less than 1. The odds ratio was 0.88 or 0.75 or 0.67. The best in the group where more ECMO was being done in more than 30 cases per year than in those where the cases of ECMO were less. So the mortality also was, as you can see, less in those centers. It was only 25% in where the ECMO was more than 30, than 41% where the ECMO was done on a sparingly level of 1:5. So this odds ratio is pertinent. It is highlighted in the yellow color of it being significant, EC being less than 0.01. If we go on to the pediatric age groups, again, this is 1989 to 2013, the odds ratio increased from 0.7 or 0.6. It became 0.98, nearly 1, to 0.84 or 0.84 again in the more than 30 cases. But as you can see, the mortality in terms of percentage was more than 30, was better in those where the ECMO being performed was more than 30. And it was less than 0.001 or significant statistically in this group of 0.84, where the confidence interval varied between 0.74 to 0.96. Vis-a-vis that, if you see the adults, the ratio was the best. The mortality was, however, higher than those in the neonates. Mortality was least in the neonates, where the ECMO center was more than 30 being performed in any one center. It was maximal. Out of 4,775 cases, it was 51 in adults, and it was about 59 in those, that is more in a smaller volume of patients where the amount of ECMO being done was less. So in patients who are slightly above 1,243, the mortality ratio was about 59%. And this was, however, not statistically done. But if you can see, the odds ratio was much better in the adults, in it being nearly similar to that of the neonates. Now, what happened when they did the similar registry or the statistical outcome in terms of mortality and numbers from 2008 to 2013? Between 2008 to 13, the neonatal period was 1.01, 0.94 and 0.85. And as we went to the pediatric period, it became near 1, it's 0.85 in those centers where the numbers were 429. Now, if you see the N of 429 with a mortality of 42%, the lesser the number of ECMO runs, the more is the mortality. Vis-a-vis that, nearly 2,500 pediatric patients, the mortality was 45, but the odds ratio was also high. So this was quite indecisive, and it was not significant statistically. If you go to the adult part between 2008 and 2013, whereas as you saw in the previous graph, the number of cases was on the rise, the odds ratio in all the three groups, that is where up to 14 or 15 ECMO runs, or between 15 to 30 ECMO runs, or more than 30 age groups for ECMO runs, if the number of cases was 3,790, the mortality was also less, 49%, and the odds ratio was less than 1.59. And statistically if you have an odds ratio, which is very closely related to the 95% confidence interval, that is the lower limit as well as the upper limit, both 0.45 as well as 0.78 are less than 1. This signifies that if you have the higher the number of cases, the lesser the mortality. Why? Because people are getting experience to perform the same technique in a much more practiced way. The mortality is less and this becomes statistically significant. As you can see, the yellow showed less than 0.001. Now going on to this, we saw what does this data tell us from ELSO, that there is great growth in adult ECMO. There is an association between volume and outcome in the full data analysis for neonates, pediatric and adult ECMO. The volume outcome association is not present in the more recent neonatal and pediatric ECMO, which was performed between 2008 to 2013, and the relationship continues to persist in better outcomes in adult ECMO right from 2008 to 2013. However, there is a inversely or a negative linear relationship, as you can see, amongst neonates from 1989 to 2013. The p-value was less than 0.001. It was 0.001 in the pediatric group between 1989 to 2013. However, in the adults, it was not significant. It was much more than 0.001. So because it was more, it was not significant. But the moment we did it from 2008 to 2013, and the number of adult cases was on the rise, the neonates pediatrics did not show a rise, did not show a statistically significant value, but the adults did. So this entire statistics, if we consider it with outcome measures of the type of support, respiratory versus cardiac versus the emergency ECMO for CPR, then you'll find that the mortality is much better in the respiratory ECMO, becoming even better when it is more than 30. The N is, if in the neonates, the number of patients is 30,909 with an incidence of mortality in 197, then the mortality, even if the number of cases are less in adults, the mortality is also better. And of the three, where is it better? Then of the three, it is much better in the emergency CPR. That means if the person has had a cardiac arrest and you put the patient on ECMO immediately, then the time loss is less, the outcomes are better, and the mortality is less. In terms of age, if we compare all three, then in terms of age, the pediatric patients as well as the neonates do much better than the adults. The female patients are doing slightly better than the male patients. The pH value is nearly acidotic in all of them and it is comparable. The PCO2 is slightly or markedly raised in almost all of them. The duration of mechanical ventilation is less. Adults are put on in a volume center where more cases are being done. As you can see, 17 versus 23 for pediatric or 22 for neonates. The cardiac arrest that you see is also less in the adult, which is comparable, but it is markedly more in pediatric patients. The renal failure is more in adults. The comorbidity, if it is present, is also more in adults. The mortality in the hospital is, however, comparable in all three groups. So it is comparable also in terms of weight. So between 1989 to 2012, if we see the support type, the pediatric patients and the neonates, the support type, the data is not there, but the adult patients did much better from 2008 to 2012. The primary diagnoses of these were mainly meconium aspiration syndrome, congenital diaphragmatic hernia, respiratory distress syndrome, persistent pulmonary hypertension, cardiac arrest, heart failure, cardiomyopathy, single ventricle congenital heart disease, and all others, but the marked ones were congenital diaphragmatic hernia, meconium aspiration, respiratory distress. But cardiac arrest was less. In the pediatric group, however, the maximum was seen in the congenital heart diseases, wherein in our center also we see CAPVCs, intact ventricular septum for arterial patient population, and alpha are the patients where maximum number of cases undergo ECMO and they do well. Amongst the adults, however, pneumonia is the highest cause with respiratory disorders. The cardiac disorders where you would want to put it would be heart failure, cardiomyopathy, acute myocardial infarction. Very little in adult congenital heart disease, but structural heart disease is not congenital, is on the rise where we can put ECMO for cardiac causes in adults. But in the sensitivity analysis from 1989 to 2013, the centers which were active in 2013, the odds ratio was less. It was less in all three centers amongst neonates, pediatric as well as adults. However, again, no random center effect was there in any of the three groups. So the odds ratio for volume increase of 30 when all other variables at their mean or reference values are seen, then the odds ratio was always more than 30 versus less than 6 in almost all groups. This also shows that right from 2008 to 2030, the more than 30 volume category is seen more in adults, or it is between 15 to 30 value is seen more in the neonates in the earlier period than where the ECMO number of cases are being seen. Now the additional volume, if you see when it is added, the p-value becomes more significant in all three groups, but it is maximally increased in the adults which are showing a rising trend now. The AIMS data from 2001 when ECMO started about 13 years back, we've done about the data, the best to my knowledge which I could get, we've done about 662 cases so far, of which 62% have been survived to discharge. The neonates and pediatrics are about 92%. We have only 8% as adult patients. 2001, the mortality was 70%. 2010, when we started to do more cases, the mortality came down to 60%, and 2014, our mortality is only 36%. So what is the cause for this? The cause is threefold. Number one, everyone knows the technique of ECMO very well now. Not only the technique of ECMO, but also how to and when to put the patient on ECMO. ECMO is very good if it is given at the right time and if it is given for a reversible condition. So if you know that this patient coming off bypass is going to benefit from ECMO, then no time waiting for dilly-dallying and putting patient on multiple bypasses. We use delay ECMO at our center. That's why I'm talking more of the pediatric or the neonatal cardiac ECMO. But the second aspect which made us decrease this big mortality rate or make it half was the starting of integrated ECMO in 2009. Integrated ECMO is a word that we use wherein we put our patients on ECMO before going on bypass. Instead of putting the patient on cardiopulmonary bypass to corrective lesion of the heart, we put the patient on ECMO bypass and take the patient, being the patient off bypass on the ECMO apparatus. So what happens, you do not lose that golden hour period of assembling the ECMO apparatus. Once the time is not lost and we are putting it indecisivenessly in a patient beforehand, preemptively, in a patient which is going to benefit from ECMO, then the outcome is also better. The patient comes off on ECMO, is wheeled on the ECMO, and within a few hours, ECMO is wheeled off and withdrawn, and the patient has less lung water. As the lungs are better, the heart is better, the inotrope requirement is less, and the patient's ICU and hospital stay better. So integrated ECMO circuit, if we have done in the right time, then of 76% have survived and about 24% have died. In those patients, when we have put in the ECMO, when we have been unable to wean the patient, then about 50% ratio rate has been, the mortality has been higher, and post-operative ECMO, the mortality has been much higher, 67%. So outcome by way of diagnosis, we have done maximum 70% have survived in TGA with intact interventricular septum rather than in TGA with the VSD. Again, the VSD, the TOP, the alpha, the truncus, and the AVSDs have also benefited. Mortality has been maximum in so far in alpha because we've done only 7 such cases. The outcome by duration run, the more than 72 hours have a less outcome, favorable outcome. The odds ratio is is also more if the duration run is more than 48 hours. So mortality by support type, the mortality is, as you can see, favorable between pulmonary, cardiac and ECPR, but the ECPR mortality percentage, though it was less earlier, is more. It all depends on what is the period in which you have treated. So this is the ELSO data again, showing that adults today are doing better than the neonates. The mortality up to 2011 amongst the neonates, pediatric and adults is almost similar, but it is better in those groups where this ECMO is put at more centers doing more volume. Now Michigan from 1980 to 1990 have also studied the impact of ECMO on neonatal mortality. And they have predicted that for every 100 neonates who are treated with ECMO in Michigan, 38 lives out of 100 are saved. And this model from Michigan can be used to predict the annual neonatal mortality in Michigan, also and other centers. Also, AIMS and Michigan all studies conclude there is a linear relationship between centers who do more number of cases, they have less mortality. In normal or thoracic ICU, the high volume center, at least one ECMO case is done every day of the year in the ward. It's a normal part of the ICU treatment. The safety will be in the walls of the ICU. Why? Because in the ICU we have dedicated nurses and doctors with experience on ECMO who are much more persistent. So what is needed for ECMO is experience, dedication and persistence, and very good cooperation amongst team members. And it is also possible to do an ECMO in awake patients, and also possible with time to learn how to solve problems. In a low volume center which is doing less than 10 patients a year, then less than 150 days per year, you need much more assistance from perfusionists. It will also be more expensive. There is lack of perfusion capacity for the operations performed on such patients, lack of beds in the ICU, and of course, if they are not doing it, the persistence to save these patients would be less. So this very famous data of ELSO is there in almost all textbooks. And I would want to say that between neonatal, pediatric and adult, mortality or the survival was the maximum, and mortality the least amongst neonates in the respiratory ECMO than in ECPR. However, in the adults, the ECPR mortality, the survival was also less. So the rates are almost the same for neonates, pediatric and adult patients. So in all the big well-developed ECMO centers, report survival rate of 70 to 80%, like the Stockholm scheme. That means that the smaller centers have lesser survival rates of maybe 50% or more. It's also possible that the experienced centers take more odd cases, aimed to Delhi mortality decrease when our numbers increase and when we started integrated ECMO. So if you see the ECMO device, which looks very, this is the conventional ECMO, my video is not playing. This is the conventional ECMO which we had been doing with the Medtronic, but now with the coming of the Mackay and the new Midos, you have machines which take no time in assembling the ECMO equipment. It is easy to assemble. Anyone who's an intensivist, anyone who's a trained OT technician, you may not need a perfusionist, can assemble this ECMO equipment. The Midos and the Mackay CardioHelp are the future of ECMO. Volume is likely a mediator of ECMO outcomes. Future studies that come up on ECMO, what is needed is research. And research will not happen till we don't have numbers. And future studies on ECMO should focus on volume in addition to process of how to measure the ECMO rates, and driving the volume outcome relationship in future research is what is needed. A high volume center takes advantage of the ECMO circuit. The goal is not to come off the ECMO machine. The goal is to have a healthy patient, and as we say, ruled implementation of free diffusion. If you start doing free diffusion like ruled implementation, then your outcomes would be better. I thank you all, and my last remark would be that the more you do, the more you read, the less the mortality. Why? Because experience and numbers teach you how to perform to perfection. This is a book which I've taken out with all good people like Venkat Goel, Dr. Pranay Oja, the ELSO people, Dr. Steve Conrad, the writer, Sunil Kovani, my friends from Delhi and in IAXA, Dr. Muralidhar Sani, Dr. Yasin Mehta. I thank all of you for making ECMO a success. It's a dent in the ocean, but let's hope it will save many more lives. Thank you all.